Hello, everyone. Welcome to today's webinar, The Battle Against Vaccine Hesitancy, What Health Systems Can Do to Reach At-Risk Patients. I'm Maureen McKinney, the Senior Content Director at Phreesia. Today, we're going to be talking about a critical obstacle that health systems face as they work to vaccinate their employees and their patients, vaccine hesitancy. According to recent data from the Kaiser Family Foundation, only 4 in 10 Americans say they definitely intend to get a vaccine, and a quarter say they probably or definitely would get one, even if it's available to them free of charge. Rates of hesitancy are even higher among vulnerable communities and communities of color that have been hit hardest by the virus. During this webinar, we're going to hear about communication strategies to manage the various reasons behind vaccine hesitancy, and we'll also hear from 2 health system leaders who will share their firsthand experiences. Before we get started, I want to sincerely thank Becker's Healthcare for hosting this event. As Phreesia is a public company, we need to present our safe harbor language. We may share statements about future plans, products, and features today. You should not rely on these statements. Any purchase decision should be based off our product as it exists today. Here's the agenda for today's webinar. First, I'll introduce our speakers, and then I'll turn it over after a little bit of discussion to my colleague, Dr. Hilary Hatch, to briefly touch on how Phreesia is supporting healthcare organizations during COVID-19, including in their efforts to vaccinate patients and address hesitancy. Then our panelists will review some of the results of their efforts so far to manage hesitancy across their health systems. And finally, we'll have our panel discussion. If you have any technical difficulties, please click on the help widget. It has a question mark icon and covers common technical issues. And since it's always one of the most frequently asked questions, this session is being recorded and you'll receive a copy of the presentation by the end of the week. We're so fortunate to have such wonderful speakers with us today. First, we have my colleague, Dr. Hilary Hatch, Phreesia's Vice President of Clinical Engagement, who will moderate our discussion. And our first panelist is Dr. Amanda Logue, Chief Medical Officer at Ochsner Lafayette General, a nonprofit health system serving South Central Louisiana. And our second panelist is Dr. Joseph Cachon, Executive Vice President, Clinical and Network Services at Ascension, a faith-based national health system serving 19 states. We're looking forward to a great discussion. First, on behalf of Phreesia, I want to sincerely thank the healthcare providers and medical staff for your tireless efforts to combat the spread of COVID-19. We are honored to support you. Phreesia is the market leader in patient intake, and we're guided by our mission of creating a better, more engaging healthcare experience for patients, providers, and staff. At any time during today's webinar, you can click the Request a Consultation button at the bottom right of your screen to learn more about how Phreesia can support your organization's vaccine management efforts. And with that, I will turn it over to my colleague, Dr. Hilary Hatch.
Thanks, Maureen. It's been a real privilege over this very difficult year to work and partner so closely with organizations across our network to quickly deliver solutions needed during COVID-19. I want to thank all of the organizations we work with for their generosity and willingness to rapidly innovate, because it's allowed us to deploy screening and triage modules, enable telehealth workflows, communicate with patients, help providers to rebuild their schedules, and now to work on this important issue of increasing vaccine uptake. We have 2 tremendous individuals here to speak about the work at their organization. I want to create a little bit of a framework on the behavioral science side to think about these twin challenges that we face in trying to increase uptake and completion of the 2-dose COVID-19 vaccine regimen. So on the left-hand side, you see a reference to the intention gap. We think of the intention gap as the gap between people who mean to get the vaccine, want to get the vaccine, but it needs to be safe, convenient, easy, accessible for them, and a frictionless experience for them to get through that process. Every year, for example, with the flu vaccine, 60% of people intend to get it, and only 45% or so get it. So we want to talk about strategies that we can use to identify those in the population that want the vaccine and make sure we get them through in a good way. On the other side of the screen, we're really talking about vaccine hesitancy, and this requires a different set of strategies and thinking, and we'll dive deeply into that today. Really thinking about not pushing people or reminding them to get a vaccine they haven't decided to get, but rather helping to understand what questions they have, understand who's a maybe, who's a wait and see if we can address their concerns. These two leaders today will talk to us about the strategies, learnings in their organization this early on in vaccine delivery. So now I want to turn it over to look at Ochsner Lafayette General's data and to talk with you, Dr. Logue, about how you've ramped up vaccine delivery since mid-December. Dr. Logue, will you tell us a little bit about your role, your organization, and your organization's role in Louisiana's vaccination plan?
Sure, good morning. My name is Amanda Logue. I am the Chief Medical Officer for Ochsner Lafayette General. We are a 7-hospital system located in South Central Louisiana. We cover about 9 parishes of our area, and we've been in this area for about 110 years, so a very well-established health system. We have about 4,500 employees, about 1,800 medical staff members. We've had tremendous growth over the last 10 years since I've been here. I've witnessed it myself and added on more facilities and also brought more specialties to the area. In my role, I oversee a lot of different things, care management, both on the inpatient and the outpatient side, patient quality, safety, and risk management. And I also oversee population health, which is sort of a very broad term for the extension of healthcare into keeping a population healthy instead of only focusing on patients that are inside our 4 walls. Certainly is not a new concept, but it's something that has been growing over the years as we engage patients more and more outside of the hospital and the clinics to keep themselves healthy and essentially keep themselves out of the hospital as needed. What that's done for us is been able to set us up with a population health model that has continued to grow over the years, grow our teams and grow our outreach. You probably have seen in the news, but in October of 2020, we merged with Ochsner Health. That was a really big move for us. Prior to that, we were Lafayette General Health. And Ochsner Health has been doing population health for quite some time, and we've been in lockstep with them for a long time. So it was really just a solidification of our joint processes and our mission together. So that has brought us more and more access to care and also more of a strategy for population health across the whole state. By having some pop health model already set up, we've been working with the state for a long time with being able to be the delivery system of needed healthcare, COVID testing, flu vaccines for a long time. So we've been partnering with them and using our resources of clinicians to travel around our area and provide needed services from that way. So when it came to moving into the idea of administering COVID vaccines, we were very well set up to get the process going, and certainly we're ready to start our strategies to see how we could get this into our employees and then to the further of the population as we grew.
Terrific. So everybody at this moment likes to see something that's a line going up that isn't COVID numbers. So here this really shows how quickly you've ramped up. And the beginning of the ramp is, of course, when you started to open vaccines to a larger population of older adults and not just your own employees. I think you're at over 10,000 vaccinations, I should say, delivered to date, and you're vaccinating 8 people, from what I understand, every 5 minutes. Now, you didn't get there overnight, so I'd love to hear a little bit more about the tools that you use, and I know you use a variety of digital tools to minimize the on-site time, digital outreach, scheduling, collection of consent, and all of the contraindications in advance, so that by the time people get there, you've already completed a lot and you can move them through really quickly. So let's talk about some of the successes you've seen and the lessons learned.
Well, certainly this slide does speak for itself in terms of what we've been able to do. We, of course, are staying in guidelines given to us by our state and by the CDC. So the determination of being able to go to larger populations is first governed by that. So we focused on our employees first and had some very quick wins and also some learnings with that. We use a variety of tools, as you said. We have digital outreach with text messaging and with pre-registration appointment reminders, automatic phone calls, and of course, some sort of old school call center also for those that need the additional help. But when we're able to push notifications to people that they're vaccinated, that they are eligible to be vaccinated, it certainly it prompts immediate interest, immediate buzz, and they want to click on it and get into their scheduling platform. The way that we're able to do that is, initiating a text message to them, follow this link that gets them to an online scheduling book that we can control the volume. And we have had to control that volume from time to time when we have adjusted from our healthcare workers to the over 70 group of public. We knew that we were going to face some barriers with needing to have longer sessions of education and a little bit longer time spent with possibly getting them consent signed or registration if they weren't able to do it. So we fluctuate those openings as we see fit, depending on the population that we're serving. And then people go in, follow the link, and they get their link after they schedule their visit. They're able to pre-register. You can see we have about 58% of our patients doing a pre-registration. That reduces our time frame when they come in significantly, so that we can go from spending 10 minutes with them to get all their registration information updated down to about 2 minutes just to confirm them, and then they can turn right around and get their vaccine, which is how we are able to run through 8 patients every 5 minutes if we are running at our full staff. So it has certainly been very helpful to have that amount of technology that helps us keep that going, and we encourage it along the way with prompting patients. Those nudges you mentioned, we'll nudge them along the way to get them to do their information again, so that they can be as efficient as possible when they get there. We've had very low no-show rate. Healthcare is always measuring no-show rates in all kinds of variety of areas because it shows us a little bit about our planning and our interest. As you would imagine, especially with these vaccines, there is very little no-show rate. People have been waiting for so long for this that they are anxious, and there's not too much that's going to keep them from showing up to that appointment.
Right. I think when we spoke earlier this week, you told me that the no-show rate is often that patients already found a way to get vaccinated at a pharmacy, and that might be why they didn't come. I think one of the things that really stood out to me here that I'd like to ask you about is the older population. A lot of people assume that they can't handle these digital processes. Mm-hmm. And it says here that 52% of older adults checked in pre-visit. Tell us a little bit about how you use digital tools to get it, continue to do that with your older population, but also what you do with those who can't engage in those digital tools.
Well, we've been using Phreesia for check-in at our clinics for a while now. So we kind of had an idea already of what our different populations were comfortable using. And it didn't disappoint during this. There was actually an increase in the amount of people over the age of 70. For those that aren't aware, in Louisiana, that's our guideline right now. We have some comorbid patients that are able to get their vaccine, but the majority of them are healthcare employees and patients over the age of 70. That's kind of where we're at the moment. And so we had an idea of what we were going to be facing going into it, but we actually saw an increase in the amount of people doing their pre-registration in that population of the over 70. I think a lot of, again, this goes back to the amount of excitement, anxiety, not wanting to miss your opportunity. And so we would have people that come in and show us at check-in, they've got everything ready. They have their driver's license, they have their insurance card, they have their screenshot of their invite, they have the printed confirmation, they have it all so they can fully prove to us that they're supposed to be there on that day, which is exciting for them. For those that don't get through it all, we have, that's been a very emotional time for them. They don't necessarily get the technology. They didn't quite figure it out. And they didn't use one of our other avenues like our call center in order to help that happen. But they show up and they may think that they have a visit and they didn't quite make it all the way through the process. That's a tough thing. We've had to have, we have our most highly skilled employees that are very good at service recovery and empathetic, because they get there and they're very disappointed and there's a lot of emotions because they have this pent-up feeling that they need to get out. And for a lot of these patients we've seen, this is their first time leaving the house in 10 months. And we've seen people that have seen each other for the first time in almost a year. And it's a lot of emotions, very happy emotions, but also just a lot of anxiety. So we help them get through the process. If we can accommodate them that day, we absolutely do. If there's a process that we can pull them aside and get them scheduled on another day, we make every effort to do that, because if they make the effort to come down there and they didn't quite get on the schedule, we're obviously held to a kind of a tight vaccine supply. And so if we can accommodate them, we will, but we do not want them to leave without an appointment that they know they can come back to, that we helped them get. So we make every effort to do that and to help calm their anxiety.
So I think giving people a little bit of a sense of what it feels like in a site where you're vaccinating 1,000 people a day at this point, and how you're making it a great experience, but also dealing with those exceptions and providing a welcoming environment. Because in the end, these are the people that are going to go back into their community and say, how was it? What was it like?
Mm-hmm.
Right?
Sure.
They're your evangelists.
Yeah. Yeah, and I'm sure Dr. Cashone could speak to this, but it's electric and it's high. It's full of emotions. Generally, very exciting emotions, and very almost this sense of a little bit of sense of relief, like I'm headed towards the end. We've done a lot of population health efforts, as I've spoken to before, but nothing on this scale. And that scale for us is quite different. So as we were going through it, we started to ramp up our volume. We certainly had to pay attention to, although we're giving vaccines to eventually end this COVID pandemic, it's not over yet. So we have to pay a lot of attention to safety and distancing. And this population has been so careful throughout 10 months. And so they get there, and the last thing they want to see is us as a healthcare system messing it all up and not paying attention to everything they were taught to do. And so they've been very critical. They've been very, I think you guys need to spread out a little further, or you need to, I don't want to wait in that corner. I'll wait over here, and they've taught us a lot of lessons, some things that we don't necessarily pick up all the way. They're also very, they want to make sure that they want to be monitored afterwards, more like 30 minutes rather than 15 minutes, because they want to be careful and make sure that we are watching them and they don't have any side effects. We have learned that it's better not to have coffee served at this location, because they'll stay for an hour and 30 minutes and chat. So it's great. It's really exciting. It's really great for our employees and our
volunteers. It's a big event.
It is.
It's a really big event.
This level of excitement and get to see the other side of the horrible year we've been through. So it's been fun, and we've learned a lot.
So let's pivot for a second and talk about your employee population. So, and that's going to lead us to really move into Ascension's data. Before the vaccine was approved, you surveyed your staff for hesitancy and discovered that medical staff was far more likely to get the vaccine than other employee groups. So it seems like what you saw in terms of the survey you did ahead of time, you saw that 43% overall of your whole population of employees plan to get the vaccine, but the medical staff, 64%, were much more likely to say they were planning to get the vaccine. Now you're still going, you're still putting people through, so that number is growing on the right, but these are the actual vaccinations, and you are seeing some differences in terms of how the medical staff is responding in terms of uptake of the vaccine and employees. Can you talk a little bit about that, and specifically what strategies you're using? You mentioned forums for specific groups, so let's talk about those.
Sure. Well, in our survey results, we also had in both the groups of the employees and the medical staff about a 30% unsure category. And so that to me was what we needed to move. That's what we wanted to make an impact upon. And we are still vaccinating people every day that are employees. And so that number is growing every day. From our medical staff, I think there's just been a bit of, over the holidays, everybody, most of our medical staff is well educated about the Pfizer trial and the side effects that are seen and everything. And we did hear some people wanting to wait to have the vaccine done so that they wouldn't feel bad over the holidays, because there's some significant side effects. And so there were some people that were wanting to just wait to get past the holidays. We're starting to see them come through now with their first doses. In terms of the rest of them that just needed more information, we certainly have done live Zoom sessions with our employees, our leaders, and with some of our experts, our infectious disease experts, to be able to answer live questions about what their concerns are. And we got some very great questions and some very common questions, and we got some wild stuff too that we knew was circulating out there. We did our best to put an end to it, or really say where is this coming from and what's really backing this information. We also have groups though of people that we have to consider that are in demographics that are more hesitant than others. And we didn't specifically measure those groups in our survey, but we know that there is hesitancy in demographics that have been hit particularly hard with COVID, and also who maybe was not as well represented in some of the studies. And so they have some concerns. We've used some of our physician leaders, some of our other healthcare leaders that come from similar demographic backgrounds, and can talk with them specifically, in their space. We've invited forums for people to be able to say, I'm African American and I don't really feel comfortable. I want to talk to somebody who has gotten this vaccine, who's also like me in that respect, and I want to ask specific questions around that. So we have open forums just for that as well too, and we're making the rounds at each facility to be able to support that group. It's been well received to be able to have just a sort of a more private session and be able to get their questions answered. And so we're going to keep doing that. This is clearly, as you can see by the numbers, we're not done. We got a lot more people to get through. And so we're going to keep making those rounds, especially as new vaccines come out.
You mentioned housekeeping and dietary workers that are particularly exposed potentially, that you were concerned about and did some of these forums for. I think that leads us into some of what Dr. Cachon is going to present from what we've seen at Ascension, and then I'll have the two of you really talk and dialogue. But Dr. Cachon, let's flip to you and describe your role, your organization, and tell us a little bit about your role in multiple states' plans on the vaccination.
Yeah, thanks, Hilary. Ascension is a 150 hospital system across 19 states, mainly in the South and the Midwest. We don't have very much in the East Coast, and really nothing in the West Coast. My role is essentially, I would say, chief physician executive for the system, but my title is fancy title, executive vice president of clinical network services. And as such, my role has been to oversee our vaccine program together with our chief clinical officer and many of our chief clinical officers across the system. and it has really been a team effort. We early on understood the issue of hesitancy. I mean, we see it in flu vaccines, right? I mean, nationally, only 60 or 70% of people get flu vaccines, and there was a lot of political overtones on both sides about the safety of this vaccine, the speed with which the vaccine came to both vaccines came to bear. And so I think there was enough issue raised in the public's eye about the safety of this vaccine. And I think it's coming back to haunt us a bit now as we, now have the reality of two vaccines that are available and people's hesitancy to get the vaccine. I think there has been some pent up demand. You heard Amanda talk about it. There were people that were kind of waiting for it. But now that next level of vaccines are going to be a little bit more difficult to get in people's arms. So we, partnered with Phreesia to try to understand that better on our patient side. We had done internal surveys of our employees, and our data really mirrored that of you heard from Amanda and Lafayette General. But we really wanted to understand our patient population and understand the demographics of who is unwilling or who is willing. We really want to focus on those folks that are not willing and understand them better, and then create programs to help us, help us resolve that hesitancy and create educational programs similar to what they're doing in Louisiana. And so we now have surveyed over the last week almost 19,000 patients through the Phreesia system to better understand the vaccine hesitancy and the reasons why, and now start to slice and dice up who are the populations that we really need to target and educate and create processes to help resolve that.
Yeah, I think if we were on a real panel, I'd hand you a glass of water right now, and I feel terrible that I can't. So I'll speak for a minute, though, while you're clearing your throat. This survey data, what's remarkable here is it's so real time, it's so fresh. The vaccine's now here, it's starting to become available to populations, and we can see what people are thinking and what their attitudes are. So this survey was developed by Phreesia. We got input from experts at Convince USA and the Vaccine Confidence Project and the clinical leadership of Ascension to really help us formulate what questions we wanted to ask. We're going to be able to just show some highlights of that data today, but we'll talk about what some of our plans are to go forward. Let's jump into some of the detail now on the next slides. So, a couple of key findings that I'll ask you to respond to. We found that 74% of patients generally agree that vaccines are important, only 60% say that they're likely to get the COVID-19 vaccine. And that speaks to what you were saying about some concern about this specific vaccine. And then we found that in those 65 and above, they are far more likely to intend to get the vaccine than essential workers, which are the two next populations sort of up as priority groups. And just to quickly define what we're saying, what we mean when we're saying essential workers, in CDC speak, it's tier B, 1B of the priority groups, but that's first responders, people who work in grocery stores, public transit workers, education, and childcare. So we found that 81% of those 65 and above report that they're likely to get the vaccine, while only 53% of essential workers report that they're likely to get the vaccine. I'm guessing you weren't totally surprised by this, but was it more than you expected, this difference?
Yeah, no, I think we were not surprised by this, and I think this story is, obviously I think people in the over 65 age group understand that they're at the highest risk. I'm a little surprised it's only 81%, frankly. And there's a little bit of selection bias, right? So people had to be coming to their doctor to, for an appointment. at a time when, maybe people were uncomfortable with that. And so there is a little selection bias. So I think these people are even more likely to get the vaccine. And the fact that only 81% are willing to get it, with all of the information that we have and the public's knowledge of that the highest risk people are the older patients. So we're concerned about that only 81%, because frankly, majority of our deaths are in people over age 80. The majority of the comorbidities are in people, in this higher risk subset. So I'm concerned about that 81%, frankly. I'm also concerned about the 53% that are, called essential workers, because they are in the public eye. They are promoting, or they are in places that could actually further, enhance the pandemic or, accelerate the pandemic. And so I'm very concerned about that population as well, because we're going to need to get to that 70% or 75% to get the herd immunity to allow us to get on the other side of the pandemic.
And tell us a little bit about Ascension's perspective on reaching high priority groups who are hesitant and harder to reach, and how that fits with your overall strategy, I think, around social determinants of health and health equity.
Yeah, Ascension has long been known for its mission focus, and specifically our mission calls us out to take care of the poor and vulnerable. And so we are many times in areas of the country and areas of the urban areas or even rural areas where we're the primary caregivers for a population of very high risk individuals that are from socioeconomic classes that typically have not accessed healthcare in the way we had hoped. And so, our mission calls us out to really specifically target those folks and really help sort of get back, or to help reduce the health inequities that occur today. And so, and that population turns out has a lot of comorbidities and are at higher risk. So from our standpoint, this population is extremely important. And it is what we're called to do. And at the same time, it is the highest risk group that makes us even more uncomfortable. Over the last 6 months, we've now collected over 100,000 data points on social determinants through the use of Phreesia. And we have now understand what percentage of our population have identified a social determinant as a potential in their life, and start to understand better that population and how the social determinants impact care overall. And now with this new vaccine data, how is it going to, excuse me again, how this social determinant data may impact people's willingness to get the vaccine, and start to do some correlations. We're not ready in terms of that analysis yet, but we are taking a deeper dive on this.
And how do you think, well, first of all, I think that analysis will be really valuable as we start to look at that and understand different populations. One of the reasons we wanted to have one regional system and one national system on this call was to talk about those differences in different areas. I think that I'm curious how this insight around essential workers could lead to formulating a strategy of outreach. How are you going to get these folks to get vaccinated? Are you going to expect them to come in? Are you going to go to them? What messaging do we put out there? Any thoughts on that?
Yes, so we have now targeted different partnerships across our communities, and partnering with churches, community centers. We were called out by the governor of Florida for our partnership with a Baptist church in the Pensacola area, where we actually vaccinated 2,500 people in a day. So we were very excited about that. So I don't think we can wait for people to come to us. We need to reach into the communities, create partnerships. Amanda highlighted the fact that there are trust issues, and we need to be able to identify what those trust issues are, and make sure that we have people that have either gotten the vaccine or are experts in the vaccine, can speak to those safety concerns that people have, and get to as many of these people in their neighborhoods and in their churches and in their community centers as we can. We can't wait for them all to come to us. And so these partnerships and community outreach will be very important. And it's being driven by the understanding of this data and where we can find people. So for example, do we go to a grocery store and say, listen, we would like to have, your employees vaccinated. We'll set up a vaccine clinic today for your employees, or in addition, potentially your customers, if we can do it the right way. And so really looking and spreading the vaccine in a way that is novel and creative. And I think we've spent so much time worried about that somebody's going to jump the line and get the vaccine early before they were supposed to. We need to spend less time worried about who's getting the vaccine and more time worried about who's not getting it, and really spend our energy on focusing on closing that gap on those folks that are not getting the vaccine.
That is a really strong call to action, and I think that it's very important. So I want to sort of go into this a little bit deeper. You're talking about going out into communities and pop up vaccine sites, and not, the mass vaccination site is a great opportunity for, again, those who intend to get the vaccine. But when it comes to really reaching out to those who are unsure, the closer you bring it to them, the more local it is, the more they know the people running it, they know the place, they're not going somewhere unfamiliar. It sounds like you're saying that's going to be a key strategy in dealing with hesitancy.
Yeah, I think it is. I've interacted with many of our patients and our employees that have vaccine hesitancy, and walk them through all the safety data, and but many times they don't know me from Adam. I'm not their doctor. I've not cared for them through illnesses. I'm not, maybe not even part of their community. And so, and not that they don't trust me, but they don't have the level of trust to overcome the fear that they need to get this vaccine. I met with one worker who told me, asked me about the vaccine. I spent a lot of time going through the safety, the 3 reasons to get the vaccine: keep myself safe, keep my family safe, and keep, a public health, a responsibility to the communities that we live. And we went through all the safety data, and I spent 15 minutes talking with her. And at the end of that, she said, well, in my religion, vaccines are a mark of the devil. And so that sometimes the amount of emotion and fundamental aversion to the vaccine there are, that people in some of their religions believe that a vaccine is somehow marking them by superhuman in a superhuman way. So we have a lot to overcome. We may never close the gap on some of those fears, but we've got to close the gap where it's closable. And I think that the more that we can do to reach into our communities, educate them, and have people that they trust be part of the agents of the vaccine, the more likely we are to close and get to that 70% level.
So let's talk about some of the detailed data that we got here. So in addition to learning that 81% of those 65 and above intend to get the vaccine, we learned their key reason and their key concerns. So in those 65 and above, keeping themselves from getting sick and dying was their top reason. And their top concerns across both groups was safety. But older people were far more likely to say that they have no concerns at all about getting the vaccine, and less likely to say how new it is or how quickly it was developed was a key concern. Whereas in the essential worker population, we saw that keeping their loved ones from getting sick and dying was their key reason for getting the vaccine. And there was a much smaller group that had no concerns about the vaccine. And this issue of new and quickly developed is really prominent in that population. And I think it goes back to one of the things you said, which is that although there may be people who are really, we can't move them. In this particular vaccine, it seems like there's a lot of maybes, a lot of wait and sees, a lot of people that are just want more information that we really need to focus on, because those are the people whose minds we may be able to see change over time.
I know this is the exact issue is I think many of the essential workers are younger They don't believe the illness is going to affect them in a way that is significant. And in those circumstances, I've had some of my own family members, nephews, that have said, I'll roll the dice. I said, the roll of the dice isn't you. You're 30 years old. You're likely not going to have any issues with this, but you're going to bring it into the house and you're going to bring it into your parents or your grandparents. And I said, that's the issue. So we have to really lean on anything we can do to convince people that this is an important vaccine. And frankly, and the safety of it. We've now vaccinated across the U.S., several million people. We've now vaccinated in our health system alone. We've vaccinated we've vaccinated over 250,000 people, both workers and and patients. We're not seeing any safety issues that are popping up. And so we continue to stress the safety of this vaccine, and more importantly, the relative risk of not getting it versus the risk of getting it.
Yeah, I think let's bring Dr. Logue back into this conversation, because one of the things that you asked me when we were talking earlier this week was you wondered about the difference in response and hesitancy in Louisiana, where the infection rate had been so high. And whether that was, I think it was a question you had for Dr. Logue, whether that would lead people to be more hesitant because they felt, well, I already had it, I don't need it, or whether they were less hesitant because they thought, wow, that was really terrible, I don't want to get that again. Dr. Logue, any ideas on that? What are you hearing and seeing?
Well, when we asked that survey question in particular, our survey was only 2,800 people, but a good portion of our employees. And we asked that question, specifically, have you had COVID and would you get the vaccine? And it was a lot lower with the number of people that would get a vaccine that had already had COVID. And breaking that down even further, specifically in that 25 to 35-year-old group of employees, I've had it before and no, I will not get the vaccine. That was kind of the largest breakdown in that particular part of the survey. Just right back to Joe's point about, they roll the dice and they've had it before. I would really call upon the FDA and Pfizer or the manufacturers, any of them, to give more information out on more often about those original patients that went through the trials back in April, May of last year. Because the longer they go on and we can update the public about how they're doing, we're coming on 9 months of them having the vaccine in their arm. And so when you look at the people that have gotten the vaccine once it was available to us, it's only been 8 weeks and they're still nervous and they're still, I don't know what's going to happen. But if you go back and look at the 20,000 people that were in just the Pfizer trial, or, the 25,000 people that were in the Moderna trial that got the vaccine, give us some updates if you can on the on the safety and efficacy that you're still seeing at this point. It's not typical, because you would normally wait for a longer period of time. They're following these patients for 2 years. They want to wait. They want to do a full analysis, and I totally respect that. However, the urgency is now, and if we can call back what's been going on for that period of time and be able to release some more information about it as it goes on, even if it's not perfect, just getting some information out there would be helpful to be able to say, look, you can see what the trend has been. Joe and I can speak all day long about how many people we've given it to that have not had any adverse effects. We've been fortunate as well, haven't had anything of severity, but it's still not always getting the message out there. And we're still talking about just 8 weeks of people, as opposed to the 9 or 10 months that have been in the trial all along. So I think that, any way that we can do that jointly, nationally, is we have to continue to be innovative with that information, just as innovative as they were to getting this vaccine out as fast as they did. We're just not done yet.
And I think, jumping off on the messaging, that this would inform messaging. It would allow us to tell stories. So when you see this data, both on your employee population and the essential workers, how do we think, and I'll ask this to both of you really, how do you think it informs the kinds of messages you either want to get out there into communities or that you want to actually test, which different messages really work? Is it that we have to impress on essential workers that they're more at risk than they think they are? Or is it that we have to sort of push on the social pressure that they are, as Dr. Cachon said, at risk of infecting others that they love? What really works, and how do we try these different things and get these messages out there?
This is really hard because this is not unique to COVID, and I don't want to get too philosophical, but this comes back to trust and having people that look like you as your physician. We're spending a lot of time on trying to, on the populations we serve, which is a very diverse group ethnically and racially. And we really want our physicians and our providers to look like the people they're treating, and in many ways have the same cultural alignment, because that's a population that they're going to trust far more than they're going to trust somebody who doesn't have their same cultural values. And so we really, and this is not just a problem for the COVID vaccine, but COVID has exposed that even further, of the lack of trust of many populations, in our African American populations and our Hispanic populations. If you're not seeing an Hispanic doctor, you don't have the same, and there is implicit bias many times about this. And so I think the more we can line up culturally line up our providers with those folks that they're treating, I think the better off we're going to be in the long run. And I think then the COVID vaccine would be a byproduct of that. And so I think this is a larger problem than COVID, but again, it has been even more amplified and more brought to the surface, this issue of lack of trust of many of our populations or our healthcare system.
I think, one of the things that makes me hopeful in what you're saying is that it accelerates that dialogue, but also actually that we are forced to learn some things in the delivery of the COVID-19 vaccine that we can then repeat for other population health issues like hypertension, or another issue that we need to reach harder to reach populations by going to them, and not relying on them to come to us. So I think all of those things are very important. As I'm curious whether there's anything you feel that digital tools can do for you, to asking on behalf of my colleagues who are so grateful to be able to support frontline providers. I think everyone on our team wants to know, could we be doing something more?
I think from my perspective, I think being agile and able to change quickly to what's going on is the most important piece of it, because being able to collect some of these data points gives us insight that we've never had before. And so being able to add those as situations change. I mean, we all know how fast things changed last year. Sometimes hour to hour, you were getting different information out there from the CDC or the government or whatever, and trying to keep up with all of that information means that we have to be able to flex that quickly with our technology too, because we have to either get information to them or request information from them. And so I think that in addition to, of course, all of the growth in things like, web-based platforms is huge, so that we're able to get messages out there on forums like this, and be able to address locally. What we found here in this area is that there were, during COVID, during last year's peaks in Louisiana, we were finding leaders, business leaders, public health leaders, things that were, organizations that were very anxious for health information about COVID. They didn't have necessarily a doctor on staff. They didn't have access to our regional medical director. They didn't really have the need for it before. And when this happened, they were just scrambling to get in touch with anybody that would talk to them. So they understood how to how to engage their employees, how to inform them about what was going on with COVID. I found that to be a huge gap. If I would get a call from anybody to talk to them about it, they would just eat it up in terms of like, I have a ton of questions. I want to make sure I tell my employees the right thing. I want to make sure that we talk to our school system the right way, the soccer team and all of my employees and our kids, you know, and they're trying to accumulate all the information that was out there, but it's still very confusing to be able to break it down and be able to give it to them so in some, you know, real terms that you can use. I find that that's probably still the case with the vaccine, and that they don't have great access to the healthcare professionals that can answer their real-time questions like we're able to do with our employees here. And I don't know exactly how we solve for that, but just better access to things like that is certainly a step in the right direction.
Well, let's talk about some of those key takeaways. I think, you know, one of the things that we're so grateful for in terms of you two participating today is everybody's wondering what is actually happening at these large vaccination sites. What are, you know, we hear about hesitancy, but there tend to be surveys of 1,000 people called on a phone survey. You're both contributing information that is very early and isn't really out there in the public eye. So I'm really grateful for you taking the time to share that information. I had put together a list of some key takeaways, but I'd like to turn it over to you as you look at those with me to see if those are, if you agree with these statements or want to add anything to them. They're on the next slide. So, you know, Phreesia is really committing to a long-term effort here to address vaccine hesitancy and uptake and share insights with not only our clients, but really the broader healthcare ecosystem. This webinar is really a kickoff for us to be able to disseminate best practices and work with leaders like yourselves to get the word out there about what you're learning. So some of the things after speaking to the two of you over the last couple of weeks that I put together is that hesitancy isn't an anti-vaxxer. It's not the same thing. We really need to understand that there are a lot of maybes and wait and sees, and that those people have questions about the COVID-19 vaccine, and we need to figure out how to answer them. That essential workers and non-clinical healthcare workers are high-risk populations that are hesitant, and the next phases of the rollout, as you said, Dr. Cachone, are going to get harder. The message, the messenger, and the vaccine need to meet high-risk hesitant patients where they are. We need to get local in our strategies, in addition to not giving up on the mass vaccination plans, because those are going to work for some people. The last point that you mentioned, Dr. Logue, is how do you get this personal recommendation? How do you hear it one-on-one from someone you trust? Your doctor or your nurse, we've known that people value that information coming from their individual doctor or nurse more than they care about what the CDC or the FDA or any political person has to say about something. They want to hear it one-on-one. So any thoughts? What did I miss on this list? Anything you want to elaborate on before we wrap for today?
You know, I would just say that data-driven solutions for getting over vaccine hesitancy is going to be very important. So however way you can garner the data, grab the data, and make those purposeful decisions about how we're going to either create a communication plan or strategies to meet people where they are, it's got to be driven by data. And the more information you get from a system like Phreesia will help you get to a point where I think you can make better informed decisions and will, I think, help resolve this issue more quickly.
So let me ask you a tricky question on that. Do you feel that systems would be willing to sort of show data on who's showing up, who is actually coming? When we tried this strategy, who did it work for? I know you're going to look at that internally, but is there a way to actually share that across systems so that we can actually identify some best practices? Is that, I mean, it's such a sensitive topic to see, you know, there's some concern right now that the people that are showing up are digitally enabled and that they're whiter than we would hope. And so I think, is there an opportunity to actually look at and understand, you know, how people are interacting with the different strategies that we take?
Yeah, I think, if we had that data, or as we get that data coming in over, as we move into more and more populations of patients, if I've learned anything during COVID, is that I want to share best practices with colleagues around the country, because there is no point. We're all dealing with the same thing. We're all dealing with the same barriers and things that make it harder for us to treat COVID or give vaccines. It's likely not that different from one location to another. I think you can see from some of our some of our surveys, and also what I've seen with some of the national surveys, they're very similar. And so we should definitely be sharing best practices, and you can do so in a way that doesn't, reveal sensitive issues about your population, but just, this is what we've learned, and this is what we've done to try to overcome it. And that's something that we've done internally, as you said, all the time. And but I think it is definitely worth the time to be able to get information like that out there. I can say that as Ochsner Health, as a system throughout the state, there's a lot of analytics that are going on regarding how much, what the different demographics of people that are coming through right now. Specifically looking at, what zip codes and stuff they are coming from, and seeing what kind of strategies we would have to do in order to get to people that have a really tough time getting access to care. We don't want them to be left out. Right now, we're working on kind of a central location, because that's sort of the easiest or the best way for us to scale up quickly, but it's not fair to everybody. It's not fair to all of those populations in Acadiana that don't have easy access to where we are right now. So very quickly, our next stages will be kind of dual vaccine access, much as Joe stated, getting out into the communities, meeting them where they are, and also continuing large volume efforts in some central areas so that we can do that together. But, if that works for one location and you can figure out a way to do it, we need to get that out there and share it with one another. So we're all after the same goal in this scenario.
Well, particularly your two organizations have shown a long-term, way before COVID, commitment to these issues. And so, Dr. Cachon, any final remarks before we close?
Yeah, I think the more powerful information is in who's not getting it, right, and why. It's less about who we can gather data on that's actually getting it. And there probably is information in there, but the most important information is who's not getting it and why, and then really target that as the solution. I would say, whatever we need to do, we need to figure out why those folks are not getting it. And that's the most important thing in my mind at this point going forward, is figure out who's getting it, who's not getting it, and why, and then target solutions. And that's what would be my closing thought on this, is let's find out why they're not getting it.
Well, thank you for that. And I think the call to action from your two organizations is really taking leadership on this issue. So thank you so much for your time, for your thoughts today, and for so generously sharing your data and your strategy. We're really grateful to you. Thank you.
Thank you. Thank you for having us. Appreciate it. Thank you.